episode in the ASMR anatomy series, and we're going to go back to our trusty, handy-dandy anatomy guide here. We kind of deviated from it for a little bit to go through the brachial plexus, which I have been pretty excited to talk about. So if you want to take a look at those videos, I might be able to add a link to the top right-hand corner here shortly. But today we're going to shift back again to this anatomy atlas, and we're going to start going through what I'm going to title the shoulder girdle, which is going to be multiple components of the bones and eventually the musculature that makes up the shoulder itself, gives us the range of motion, and allows us to do what we do as people. And we'll start actually that with the humerus bone, which is the long bone of your arm. But before doing that, just wanted to take a second and say thank you to everybody who's watching, who provides suggestions and things like that. I got one recently, a request for a phlebotomy video, so might be looking to do that here in the near future, just kind of forecasting into the future. That would be something fun for me to prepare and present to you guys. So thank you for those of you who've been watching. Thank you to those of you who subscribe to stay up to date on all the video releases. And if you like this video, please do like it, because that causes the algorithm to promote it to other people who might like it just like you. Alright, that out of the way, let's get into this. All things anatomy and shoulder girdle. So starting out with the humerus. This is the right humerus shown here. So it says the head of the humerus articulates with the scapula at the glenohumeral joint. So it's going to be with this juncture here, the head of the humerus. And the capitulum and the trochleae of the humerus articulate with the radius and the ulna, respectively, at the elbow or cubital joint. And so the capitulum here is going to go with the radius, and then the trochleae is going to go with the ulna here. So we'll go ahead and go through the features that are highlighted. So we've got a greater tubercle, and one thing that is helpful to know is anytime you hear tubercle, you more often than not can think that that's going to be an attachment point for a muscle or a ligament, because that kind of tuberosity sticking out is a great point for those muscles or those tendons to latch onto. So, greater tubercle of the humerus, we've got an inner tubercular groove, we've got a lesser tubercle, same thing as the greater tubercle as far as concept. We've got the anatomical neck, the surgical neck, the crest of the lesser tubercle, the crest of the greater tubercle, and then the deltoid tuberosity. And that means that that's, again, going back to the tubercle point, this is an attachment point for your deltoid muscles, which if you see somebody that has really well-defined shoulder muscles, that's your deltoids more often than not. Here's your anterior lateral surface, your anterior medial surface, which makes sense. So we know that this is the lateral side, because again, this is the right humerus. So we're looking at somebody head on here. If they were supine, then their hands would be down, and so this is the right side. And it's showing us this here with this picture, but I know that the orientation may not be the most clear. We've got the lateral supracondylar ridge. We've got the radial fossa, the medial supracondylar ridge, the coronoid fossa, the medial epicondyle, and the lateral epicondyle. And then the capitulum and the trochleae together are called the condyle of the humerus. So again, here is that anatomical neck. We saw it here, now we see it from this orientation. Greater tubercle, intertubercular groove, lesser tubercle. So again, this is a lateral view, so we're looking from the outside in. And then this is going to be a medial view, so from as if we were at the patient's rib cage looking out at their arm here for this one. So here's that medial border, lateral border. I'm sorry, I misspoke. This is your posterior view. This is your posterior view. This is going to be your medial view. I got ahead of myself. So here's the shaft of the humerus. There's the medial border, and that's why we can see the medial border here and the lateral border here. Forgive me. Here's the radial groove, that greater tubercle again, which we can straightforward as far as once you've covered the major features. Here's a distal or inferior view, so looking bottom up. Another view of that trochleae and the capitulum, and then that capitulotrochlear groove. Here's an ulnar groove over here that we couldn't see as easily. It's kind of obscured by the specific view. And then I know you all, hopefully you enjoy them like I do. We've got ourselves another clinical box right here. So fractures of the humerus. This is an anterior view of the humerus. Fractures of the proximal humerus are very common and occur predominantly in older adults who sustain a fall onto an outstretched arm or directly fall onto the shoulder. The three main types are distinguished. So when it says fall on an outstretched arm, just imagine somebody who trips and you go to brace yourself and you put your arm out like this and you land on your hand extended. That pressure is going to displace up your arm and into the head of your humerus here. So again, orienting ourselves, here's the greater tubercle and the surgical neck. They call it the surgical neck in part because that's usually where surgery is done on the humerus, because it's a weaker point of the bone, especially in osteoporotic patients or patients who have osteoporosis, which is a condition of weakened bone, if you weren't familiar with that. Here's an extra-articular fracture, and that you can see it kind of runs along the periphery of the two. It can be on the periphery of the points. And then a comminuted fracture kind of looks like X marks the spot, unfortunately, and it tells us more about those here. Extra-articular fractures and intra-articular fractures. This is an extra-articular at the surgical neck. Intra-articular is as shown in the comminuted. Extra-articular fractures and intra-articular fractures are accompanied by injuries of the blood vessels that supply the humeral head. So here, interior and posterior circumflex humeral arteries with the associated risk of post-traumatic avascular necrosis. Now, avascular necrosis, or AVN, is a pretty nasty condition where if any blood vessels are damaged that supply blood to the bone in the area, the bone will just rot and die and just be completely gone and not functional. I first heard about avascular necrosis because this sometimes happens with the head of the femur, and those patients, if they experience avascular necrosis, have to have an entire hip replacement. So this is a little bit different. This avascular necrosis can be secondary or following a fall if any of these blood vessels sustain damage due to the nature of the fracture itself, tearing or shearing the blood vessels. Fractures of the humeral shaft and distal humerus are frequently associated with damage to the radial nerve. Not good. Not good. And again, that's kind of in part because of the relationship with the brachial plexus, which we covered before. Let me see. So the joints of the shoulder itself. So the overview, right shoulder anterior view, we've got the subacromial space, which is right below the acromion, which makes sense. The acromioclavicular joint, which is aptly named because the acromion and the clavicle come together at this joint, so that's the name. The scapulothoracic joint is going to be between the scapula and the thoracic cavity here itself, and then the sternoclavicular joint between the sternum and the clavicle, which we covered in a previous unit. So the scapulothoracic joint, we've got a right-sided superior view. So this, and then we're just turning it up and looking down. This is what we've got here. We can see that AC joint is called AC joint for short, acromioclavicular AC joint, with the acromioclavicular ligament, the coracoacromial ligament, so that's connecting the acromion process with the coracoid process. And then the glenohumeral joint is just kind of like a tough fibrous capsule that goes holding the head of the humerus into the glenoid cavity. So glenohumeral holds the humerus and the glenoid cavity together. And then again, that scapulothoracic joint. So in all movements of the shoulder girdle, the scapula glides on a curved surface of a loose connective tissue between the serratus anterior and the subscapularis muscles. This surface can be considered the scapulothoracic joint. So we've got the subscapularis muscle here in red. We've got the scapulothoracic joint indicated in this right here. And then here's the serratus anterior. Yeah, and so all of these working in relationship together allow the glenoid, or the head of the humerus, to slide and rotate within that glenoid cavity. And then we've got the sternoclavicular joint. Again, we kind of covered this in the mediastinum unit. The anterior view of the sternum with coronally sectioned on the left side. A fibrocartilaginous articular disc compensates for the mismatch of surfaces between the two saddle-shaped articular facets of the clavicle and the manubrium. Okay. And then the acromioclavicular joint, which we talked about over here. This joint is a plane joint. Because the articulating surfaces are flat, they must be held in place by strong ligaments, greatly limiting mobility of the joint. And this is actually, when there's damage to that joint, what can happen if there's damage to this joint, a partial tear or a sprain. You might hear somebody say that they've got a sprained AC joint or a sprained shoulder. What can happen in those cases if someone takes blunt trauma to the outside of the shoulder that hits this acromioclavicular joint? It separates the attachment of the acromion and the clavicle, and so the clavicle can pop up. And so there's multiple degrees of separation, but if you ever hear somebody say, oh, their shoulder popped out, that's how they'll commonly refer to it. That's the clavicle popping up off of this shoulder joint. So, and this is just kind of another view of what we've reviewed already. I guess it is worth highlighting again. This is an anterior view of the right side. Okay, and then we've got another clinical box. Love these. Something fun to talk about. And this may actually be about to talk about what I was just talking about with the AC separation. A fall onto the outstretched arm or shoulder frequently causes the dislocation of the acromioclavicular joint and damage to the corticoclavicular ligaments. Now I hope, there's a part of me that hopes that whenever these clinical boxes come along and confirm what I was just saying, it gives me a little bit of credibility. I hope. I pray. Come for the ASMR and stay for the fun facts. So here's the stretching of the acromioclavicular ligaments, the rupture of the acromioclavicular ligament, and then we can have. So this is stage 1. Here's stage 2 is the rupture, and then stage 3 is complete dislocation of that joint itself. And I think, this is by and large just a review of what we had just covered, but I think we will draw this video to a close here and combine the glenohumeral joint with the bursa conversation, because the bursa is it's kind of like an airbag for this joint. So I'll go ahead and we'll say that this portion is the shoulder girdle, and then part 2 will be, or we can just do a part 2 of the shoulder girdle. And beyond, we'll start getting into some of the musculature of the shoulder and the arm. But we'll go ahead and draw this to a close for now. I appreciate you all taking the time to watch. If you have any questions, comments, thoughts, I'm always open. Love interacting with you guys, so I appreciate that. Don't take it for granted. Hope you all have a great rest of your day.